Okay, everyone, I'd like to introduce our next speaker, Rear Admiral Joyce Johnson. She is the former Director of Health and Safety for the U.S. Coast Guard. In 1997, Rear Admiral Johnson became the first woman to hold the post of Chief Medical Officer and Surgeon General for the U.S. Coast Guard, and she was also the first woman to attain flag rank on active duty with the Coast Guard. Rear Admiral Johnson has extensive international health experience, and she's provided consulation and clinical care on all 7 continents. She is a physician who is board certified in 3 specialties: public health and preventative medicine, clinical pharmacology, and psychiatry. Her areas of interest include emergency preparedness, third world healthcare, and health systems development. In addition to her medical degree, Dr. Johnson holds a master's degree in hospital and health administration. She is also among the first to engage in AIDS research with the Centers for Disease Control in Atlanta, Georgia. And her previous work includes roles with the U.S. Food and Drug Administration, the National Institute of Mental Health, and the Substance Abuse and Mental Health Services Administration. Please join me in welcoming Rear Admiral Joyce Johnson.
So, first of all, can you hear me? Okay. And my usual style is discussion. And I can tell from this group that will not be a problem. At the same time, I have sort of a couple of themes or messages that I would like to communicate. So why don't we try this? If you have a burning question, raise your hand, and we'll try to answer them as we go. But if we find out that doesn't work because there's too many of them, either we'll just have a discussion, or I will ask that everybody be quiet until the end. So we'll kind of see what we can do. Basically, what I'm talking, first of all, are any of you in sort of, I looked a little bit about your backgrounds. It doesn't seem like there's too many of you that are really in the healthcare discipline. Is that true? Okay. But sort of what my theme here really is that I'm using health more as an example. And really my overall message is that cultural diplomacy is something that's for every one of us, whatever our discipline, whatever our interest. Though most of the things I'm going to talk about here have an international range, cultural diplomacy is something you can do no matter what community you're in. You can do it, you know, with your neighbors for all practical purposes. So we're going to talk a little bit, there's really 2 themes. One is health, to give you sort of some didactics about health in the United Nations, and the other is what you can do individually. And do we have a PowerPoint? I mean, a remote?
We don't have a gadget, but if you just want to nod to me afterwards.
Okay. Basically, what is culture? Culture is the shared, can you all see this? Because there's some of these you're going to want to see. If not, well, I'm going to be brave and I'm going to move this a little bit. Did that help?
Okay, we're going to have to move it.
Yeah.
We may need, I know one of you is an architect, you may need the engineering part of that too.
I think that's good. Can everyone see? If not, we can kind of try to jiggle it while Rear Admiral talks.
Some of you are going to need your neck treated, I think, by the end here. But anyway, basically, culture is the shared way a group or social unit does things. And it really includes everything that you do. It includes your food, your housing, clothing, a lot of the values, and sort of everything, as well as health and medical practices. And what is diplomacy? Diplomacy is the dialogue or negotiation between groups or states. It's the communication among 2 parties, often with the aim of confidence building. It's the employment of tact to find mutually acceptable solutions. Can we move this, maybe?
Yeah, let's get that out of the way.
And why don't we put this here? We're gonna, maybe we can do puppetry. Okay, so that's there. Let's put this here. Let's put this here. Can we put that there? We're going to find solutions. Is that going to not work? Is that going to go this far, or is that not going to go this far?
I don't think it's going to go that far, but maybe you can put it on a chair.
Okay, let's put that on a chair. And then down is just, okay, yeah, that's fine. That's good.
Yeah,
that's much easier. Okay, perfect. This is down?
No, to the side.
Okay. Okay. And what is health? And this is, since most of you are not from a health background, probably the other things are probably reviewed. But health is this is the United Nations definition of health way back from the 1940s. this is still the most commonly used definition of health. And it's a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And that really is a global perspective. And the focus there really is on health. It's on the positive aspects of health, not on the negative aspects of disease. It's also been described as a resource. It's interesting to think of health as a resource, but it really is, because in order to do things, it's something you need for everyday life, not the objective of living. Health is a positive concept emphasizing social and personal resources, as well as physical capacities. And what are the determinants of health? What are the things that go in to make health? The social environment, the economic environment, and the physical environment, as well as the individual characteristics of the person. You can kind of divide it into three health fields. One is lifestyle, or the decisions a person makes about what they do. Can you give me a couple examples of lifestyle as related to health?
Running marathons.
Running marathons. Excellent example. Eating cookies outside. And environmental, which is really the external things around us that we can't control as an individual, but there are many environmental things that we can control as a society or as from a public health perspective. You know, lead in water is an example, even the availability of potable water. And biomedical, which is genetics and is more the physical things that we are sort of given with. Okay. Let's talk a bit about the United Nations, since that's really the theme. How many of you, maybe all of you, how many of you were at the UN in New York? Okay, so essentially all of you. When you were there, though I realized WHO is in Geneva, did you have any orientation to the World Health Organization? No. Okay. So the World Health Organization, okay, as we saw before, health is really broad. It includes really almost all parts of a person's being. Because of that, there's many different parts of the United Nations that has a relationship to health. You know, the environment has a relationship to health. Economics does. I mean, almost everything does. But I'm focusing primarily on the World Health Organization today. But it's all the parts are interrelated. The WHO, which is the usual way people would describe the World Health Organization, is in UN terms a specialized agency. And it was also established in 1948, and it's based in Geneva. The objective is the attainment by all people of the highest possible level of health. The original priorities that WHO had included malaria, which is still a worldwide problem in a tropical area, women's and children's health, tuberculosis, venereal disease, nutrition, and environmental sanitation. Those were the priorities back from the late 1940s. In all of our countries today, malaria maybe not because of geographic issues and because of the mosquito population, but basically these priorities are still very, very relevant to today's world. I'm not sure if that's a positive statement or not. Also, WHO is responsible for the International Classification of Diseases, which if you're not in the healthcare arena probably isn't that important to you, but for those of us that practice medicine, it's extremely important, because the International Classification of Diseases is what determines what is a disease, which then goes on to third-party reimbursement, what health insurance pays for, how things are described, how research programs are oriented, and it really has a major impact on the entire health arena. What are the priorities have changed over time, as we might expect. At different times, certain things, yaws was a serious problem at one point in time. The one thing that WHO is really credited with is smallpox eradication. And the way that was done was really through vaccination. And some of my friends went to developing countries where smallpox was common, and they literally went door to door to make sure everyone had been vaccinated. Now, this is a young audience, so this is going to be a test for you. How could you tell if someone's been vaccinated? Somebody I'm not going to comment about age, but I can almost tell by those who can answer the question. Okay, yes?
You get the pox,
Right. So basically, the smallpox vaccination is a live viral vaccine, and you sort of do a scratch you scratch it, and then you get a big oozing scab. And when that scab falls off, especially if you're not very careful, you'll frequently have a scar. So if you were going door to door looking to see who had been vaccinated, that was one way that you could tell. And the vaccination program is really what had a major, major impact on smallpox eradication. A disease that there's great efforts in trying to eradicate now is polio. And polio is, okay, smallpox is basically spread through the air, very contagious from person to person. Polio is a very different kind of disease, and it's spread by the oral fecal route. So in many third world countries, it's spread by contamination of drinking water. And it was found, and I won't mention which country, but it was found in one country that when the water supply actually got better, the rates of polio increased, which is very contrary to what usually happens, because normally if the water becomes more potable, people's health gets better. The reason for that was that polio was so common that there was enough virus in the drinking water supplies so that people essentially took an oral vaccine when they drank the water. They had very low dose of the virus. They were able to develop antibodies against it, which was sort of a vaccine. And when they purified the water, that no longer happened, and that was the reason for the increase in the polio rates, which is sort of a piece of trivia. I'm full of trivia here. Okay, then there was HIV/AIDS, back in the early 80s, and SARS and other emerging infectious disease. And one of the things that WHO does is if there's an emerging disease or a new outbreak, they put a lot of resources into it to try to have the countries work together. We really are in a global world. Disease outbreaks, though they may start, well, SARS is an excellent example of that, is when disease starts in one place, it really spreads. Avian flu is another example. There's a lot of examples of that. And HIV/AIDS as well. I worked at the Centers for Disease Control in 1981 at the very, very beginning of the AIDS outbreak, and I was one of the first AIDS researchers, so we could talk about that if we wanted to. But other things WHO does is it advises ministries of health, and does a lot of emergency response things. And chronic diseases are something that are now taking more, they're gaining more attention. Everything used to be, not everything, but infectious disease used to be the primary focus. But as more and more countries are improving their overall health status, chronic diseases are becoming more and more of an issue. Even obesity is a real problem in many countries where you can have obesity and starvation really right next to each other. And then what's on the bottom there are the Millennium Goals. I'm just going to briefly talk about these. These are actually the UN Millennium Goals, not just WHO. But the reason for this slide is to show you how intertwined health and health-related things are into the overall UN mission. And I won't bother to read those, but you can see how most of those really are related to health, even if they come from a different directorate. Okay. The headquarters are in Geneva, as we mentioned. And these are the, WHO has 6 regions. Now, what I'm going to do with the next series of slides is I've done work with WHO in each of the regions at one time or another in my career. Now, the things I'm going to talk about are not the most important things WHO does. That is not how I made these selections. The reason I chose these things is because these are the things that I did. And so it's really to show you that things that may not be the most important from a world scale can still have an impact and can still be very, very fun and interesting to do. So this is not any kind of representative sample of anything. And the countries are also not a representative sample. They just happen to be the countries that I did these things in. Okay, so if we talk about Ghana and maternal and child health. Maternal and child health is a major issue in almost every country, including the United States. The United States' statistics for maternal and child health are not something we're particularly proud of either, particularly with underserved populations in our country. In Ghana, what we did is that the WHO has an extraordinarily organized and concise approach to a whole host of different determinants that affect maternal death rates and infant mortality. In Ghana, 1 out of 9 children dies before the age of 5. The infant mortality, or the maternal mortality rate, is about 350 of every 10,000 births. It's very, very high. It's 34th in the world. And it's, at least in my experiences, it's particularly high with cesarean sections, because if you have a cesarean section, you have all the issues with infection and just a lot of other issues. But at the same time, on the positive side, there's some relatively simple things that you can do that can have a major impact. Many of the women die from bleeding. So if you teach the local, both physicians as well as the local midwives or the people who are attending women during childbirth, how to deal with bleeding, you can save many, many lives. The same thing with infant resuscitation. There's simple things you can do if you have what's called a floppy baby, if the baby is having problems at birth. There's many things you can do to help resuscitate that baby and then have that child lead a normal, happy life. So what WHO is trying to do is focus on what are the primary problems that can be treated with relatively few resources. And that can have a tremendous impact. Even in Ghana, if you look at the rates of maternal death and infant mortality and under 5 mortality, the rates are really dropping dramatically. Not only because of this, but because of a number of programs. And one of the things that WHO does is that the education programs are really, some of them are focused towards the healthcare providers, and healthcare providers at all levels, as well as some are provided to educate the women about what to do. And I think all of these are WHO posters, some of them may not be, but, and it's really hard to see, I realize, but the focus is really on really encouraging women to breastfeed. Breastfeeding is so important. Do any of you know why breastfeeding is so important? Particularly near, yes?
You will give the child the mother's immunity.
So one reason is immunity. In areas with unsafe water supplies, there's even a more important reason, and that is that one of the causes of pediatric diarrhea, which is a leading cause of infant mortality, or I'll call it children before they're weaned, which can be anywhere from 1 to 4 years old, 5 years old some places, is that the kids then drink the contaminated water and they get diarrhea and they die from the diarrhea. So if they focus primarily on the mother's milk, that increases the immunity, but it also decreases the amount of other contaminated food they have. Another problem, which was the issues around the Nestle boycott some years ago, is that many of the formula products are powdered, so they're made with contaminated water. The other thing is they're extremely expensive. And so that a family cannot afford them, and so they will dilute them down, and then the child does not get enough nutrition, which can have major impacts on the child's growth. When I was in Papua New Guinea, it was illegal to have a baby bottle. And if a mother died, then another woman tried to breastfeed the child, or they would just feed the child with a spoon. Did you have a question? Oh, okay, sorry. Okay, this is Guatemala. One of the things that actually my husband is back there, and as a family, we go to Guatemala usually once a year with a group, doing different kinds of volunteer medical care. We go around Lake Atitlan. I don't think any of you are any of you from Guatemala? Okay. And so one of the things that the physician who led the trip has gone down for 20-some years, and with one of the projects that she does for WHO is she weighs and measures the children in the grade school and in sort of the middle school. And the reason why that's so important is because there's, like, one of the things that's key in monitoring kids is to have their growth chart. Well, the growth charts are different in different areas and in different regions. Some do, back to our little list there, there's genetic differences in the size that people are. There's environmental differences, and there's certainly nutritional differences. And so WHO keeps a list of, has data on what are the usual growth patterns in different areas. And so we were measuring and weighing kids to provide data, longitudinal data to that. And, okay, Morocco, okay. This is the Collaborating Center for Pharmacovigilance. Now, it sounds like a lot of big words. So pharmacovigilance is sort of the term used usually in the United States, is post-marketing surveillance. But what that really is evaluating drug safety after the drugs are on the market. And Morocco, I chose Morocco here just because Morocco is one of the countries that's a participant. The Uppsala Collaborating Center in Sweden is kind of the primary organizer of this. And what happens is, and this has been going on for many, 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 many years, is that the different participating countries collect data on adverse drug reactions. Usually the reactions that are most interest are serious reactions, and there really should be events, because you don't always know if there's a cause and effect relationship. But serious events that are not in the package labeling, you know, I think in all countries if you get a drug there's kind of the established side effects, but that are not in the package labeling. And what happens is that all the different participating countries submit their data, their reports to the World Health Organization. The World Health Organization then has a very large database. And that's important for a couple of reasons. One is, if you're in Morocco or if you're in wherever, you may not have very many cases of something, so you don't really, you know, your 1 or 2 cases may seem random. But if all the different countries put their cases together, coupled with the different environments and different indications these drugs are used, the different way the drugs are used, coupled with the genetic variations, you can have a much more meaningful database. And this has been a very important thing, because in clinical trials, you can only, if you have 3,000 people in a clinical trial, you're only going to find something that happens in a rate about 1 in 1,000. If you have 30,000 people, you'll find something hopefully that's in about 1 in 10,000. But many of these serious rare events, like I know a number of you are from the US, did you hear about on TV? These may happen in 1 in a million. You know, these are not common things. These are not something you're going to ever find in clinical trials. And so the overall world, the Collaborating Center for Pharmacovigilance is really an organized system. The other thing that's a part of WHO is CIOMS, which is the Council on the International Organization of Medical Sciences. And I've been on several CIOMS panels or committees, and what we do is take one issue, and when I was on it, it was primarily a handful of European countries, but what we tried to do is look at the regulatory authorities in each of those countries, and it was a combination of both the regulators, the government, like in our case, I was working for the Food and Drug Administration, coupled with industry, and looking at what do the different regulations say. We all recognize trying to change and trying to harmonize regulations is a big job and not usually the first step. But what we did is we said, given the regulations, what are the different ways that we can make things more similar? So for example, when the pharmaceutical companies have to report the adverse reactions reported to them, we established a standard form, which then made it better for them because they only had to have one form, but it also made the overall data collection much better because everybody had the same information. Okay, tobacco. Okay, the European region, I picked the Ukraine because I was in Kiev about a year ago. And one of the things that WHO is doing is they have what's called the Tobacco Lab Network. And what that is doing is that, and there's a lot of other kinds of tobacco control activities. So this, as I said, I'm not trying to be representative here. I'm just picking like little isolated things. Sort of like a polka dot dress, I'm picking a few dots. And so what the Tobacco Lab Network is doing is it's establishing standardized ways in which both the components of tobacco as well as the smoke can be measured, so that and we're trying to use technologies or procedures that use equipment that most countries can have. We're trying to make it an affordable process and also do it in such a way that I think there were maybe 20 countries represented, so that one country can do the testing for another country as well. Anyway, I don't know if you can see these, but these are some of the spectroscopy equipment that we use in testing the tobacco. And this, we don't probably have a pointer either. Okay. Public time. Okay. The equipment on the right there, on the left, is a smoking machine. And so these little things up there are cigarettes. And so what the machine does is the machine smokes the cigarette, and you can set the machine up so it smokes the cigarette more or less like a person does. There's a lot of scientific controversy about is it exactly the same or not. And then you take the smoke, and then you can study the smoke and look for particulates and different kinds of chemicals to try to assess how dangerous the smoke is. We all know it's dangerous, but there's sometimes relative amounts of dangerousness. And the other picture, this one is my favorite, so you have to see this one. This, I don't know if you can you see the smoker's body? That was a poster that was up. Actually, I think that might have been in Ghana that I took that picture. But anyway, so that's what the Tobacco Lab Network does. But WHO does a lot more things than that related to tobacco control. Okay, so this is Bangladesh and an international safety conference. This was a very interesting conference because there were people from many different countries there, and the agenda on the conference was organized by problem. So, for example, one of the problems was drowning. Drowning is a major cause of death in Bangladesh, particularly among small children. You know, because it doesn't take very much water for a child to drown, particularly a toddler if they trip and fall, which is what toddlers do. So on the panels, there would be, for example, someone from Bangladesh that talked about drowning in floods. In the US, what is most drowning due to? At least accidental drowning in kids. Swimming pools. Exactly. So another group talked about swimming pools, but the idea was to try to talk about what are the means of prevention and control. Can one group learn from the other group? There was also a lot of emphasis on other kinds of safety things, such as automobile safety. You know, that automobile safety is an issue worldwide, and domestic violence and some other kinds of safety issues as well. Okay, this is Papua New Guinea. About almost 60%, well, about 85% of the world's children are vaccinated. And about 60% of the vaccinations are due to UNICEF, WHO, UN participating organizations or entities.
The Rotary Club.
What?
The Rotary Club.
In the Rotary Club and lots of different groups. When I was in New Guinea, what we did is we actually had a malaria researcher, and there were about 4 of us, and we went out and dug out canoes, and we went out to the villages that were literally in the middle of nowhere. And then we would portage back in and then stay in the villages and we looked for tuberculosis, filariasis, malaria, and then we did the routine vaccinations. And the physician who I was with, who lived in sort of a, well, lived in a compound, I guess, had recipe, and also there had been a major polio epidemic there 5 years earlier, and she had recipe cards. And she was incredibly organized, because this was an area where there was no money economy. And so she had recipe cards, and when she would go to the villages, she would try to identify the children's names. Well, that was a major problem. And the reason that was a major problem was for several reasons. One is that the children didn't get names until they were older because the infant mortality was so high. There was concern that if the children had a name, the spirit could find it and the spirit would take the child away. The other thing is that it was in a culture in which men tended to have several wives, and so it was very difficult to identify sometimes which of the children were in which nuclear family because they didn't really have a nuclear family. You know? And I think these are the kinds of things that when we work in different places, we need to be very appreciative of different cultures and different ways of doing things and not put our values on the system. Mm-hmm.
How did the people respond when you brought in that kind of technology? I mean, were they afraid of you or did they receive it?
Okay, she had gone there every 3 months, 4 times a year, every 3 months for some period of time. And one of the things that we did that, in answer to your question, is, okay, so that was in the time when do you know what elephantitis is or filariasis? Mm-hmm. Okay, just real quickly. It's a little worm. The worm will migrate into the lymph nodes. When it reproduces in the lymph nodes, it causes fibrosis. And then the fibrosis is what causes the major swelling in the legs, the arms, the breasts, the scrotum that you see. And it's called elephantitis because it's big like an elephant's leg. And so that was a disease that was very endemic there. And one visit before, she gave the people a medication which was supposed to kill the worms. Now, even if you kill the worms, you're not going to change the fibrosis that's already there, but you can prevent future problems. So what we needed to do to assess whether or not the medication worked is we had to look at their blood under a microscope. Okay. Well, this is an area that had, I mean, they didn't have wells. I mean, they had no electricity, no nothing. But we had little microscopes, little Bunsen burner microscopes. So we used those. And the other part of this, though, is that the worms were believed to come out into the peripheral blood at around 2 o'clock in the morning. So we had to get everybody there at 2 o'clock in the morning to get their blood tested. Now, when she told me we were going to do this, I sort of said, sure we are. So I thought, who in the world is ever going to do this? Well, and we were at the equator, so you have 12 hours a day, 12 hours a night. So when the sun started to go down and it started to get dark, from way back in the distance, you could start to see the people coming. And for light, they had sticks with fire on the end so that they could see where they were going. And everybody came. And I realized they had nothing else. I mean, they had no TV, they had no radio, we were their entertainment. And so we drew their blood, and they were quite happy, or no signs of not being happy. And we showed them their blood under the microscope, and it was actually, I think, an entertaining thing for everybody. So if that answers your question. The other thing is, well, yeah, that's. So I didn't have any problems that way, which kind of surprised me. But okay, Antarctica is not really. The reason why this is on here is not because of the UN connection at all, but rather because I think Antarctica is one of my favorite places, and I've been there several times, so that's probably the real reason why I'm showing the slides. But the other thing is that Antarctica is another example where many countries work together harmoniously. Antarctica, 47 countries have signed the Antarctic Treaty, basically saying that no one owns Antarctica. There's no Antarctic flag. It's not a country, and that everyone agreed that it's a peaceful place, and that its purpose is science, and that everyone has a responsibility for environmental protection. And this is sort of a list of the countries. But the reason why this relates to health is that when I was there, there was someone who got into they have sort of, I'll call them snowmobiles, got into a snowmobile accident and was seriously injured. Well, I was in this part there, and they were over on the farther end. And it was amazing how everybody worked together. The Italians took one of their planes. Everybody worked together to collect the patient, bring the patient step by step. The patient then ended up at McMurdo and then went on to New Zealand. But it's everybody works together in an environment like that because you have to. And these are just Antarctica pictures, but Antarctica is really a desert. And what this is this is in the dry valleys, and these are rocks. And there's wind, and the wind comes, and the wind is what carved these out. And these are big. These aren't like little, they're big. The thing that's just so amazing is how big everything is. And when you see it in a picture, it's kind of pretty, and if it's a penguin, it's kind of cute. Well, I mean, the penguins aren't that big, but everything is huge. It's amazing how big it all is. So these are just a few pictures, which you can't really see, but you can close your eyes and imagine.
When would you go to Antarctica if you were to take a trip there?
Okay, I've only gone there for work. And so when I go there for work, I've been to the South Pole twice, McMurdo twice, and then the U.S. has 3 stations there. McMurdo Station, which is the one that you go to by way of New Zealand, and that's the largest station. It has maybe 1,000 people wintering over, so it's the largest station on the continent. And then the South Pole Station, which is maybe a 3-hour drive, a 3-hour flight from McMurdo. And now the pole is landlocked. There's no water around it. So there's no animals. And when I say there's no animals, I mean there's no animals. Because even at McMurdo, the only animals are water animals, because that's where, and there's a few bacteria that we're finding now, and probably some viruses, but anything you can see is water, and there's no plants. And so at the pole, it's just white. It's cold and it's white, and there's no animals. And back when they had the dome, which was sort of like it became under snow, but it was sort of like a Quonset hut cave kind of thing, is that to store the food, they just had to store it in the hallway because it was that cold, and there were no animals. There's no mice, no flies, no gnats, no mice, no nothing. We're here. If you left a box of fried potatoes outside, something would eat it, but there's nothing there. So it's a totally different world, and almost everybody there is between about the ages of 20 and 35. Almost no old people and no children. Everybody dresses the same because everybody has their warm clothes on. There's almost no status because people, when they get their paychecks are deposited in the bank, and so they have, there's a little store where you can buy, toothpaste. So you don't need any money, so money is no longer an issue. Clothes are no longer an issue. Nobody looks too great because you're all kind of cold, so that's not an issue. Education doesn't even make that much difference because people, one year there was a physician who went as a bus driver because he really wanted to be in Antarctica. So even education isn't that much of a determinant. It's a totally unique social environment. And those are you have to have penguin pictures. Okay, so cultural diplomacy and you, we might as well get back on topic here. These are examples that really show how cultural diplomacy have affected my life. But the real message is, whatever your area of expertise, cultural diplomacy can, and more importantly should, be a part of your life. We'll just go through a little bit of things here. Cultural diplomacy is not me. It's not I am right. It's you are right too. One of the things is you have to live with ambiguity. You have to live with the idea that there can be different ideas and one isn't more right than the other. That they're all allowed to exist. It's not my way is better. It's what is your way, and maybe together we can find a better way. Yes?
On that point precisely, when it comes to health, what sorts of issues do you see there where there's space for compromise despite the hard science around it?
This is a very good question because I have very strong feelings about this one too. Can you all hear what his question was? In the area of health where there's hard science, how do you deal with the culture? You have to deal with the culture or the science doesn't work. I think it's extremely important to understand what it is the people do and why did they do it, or how is it all part of their culture, and then as it's part of their culture, then you can begin to educate people about, you have to set your priorities, you have to set your battles. For example, I was in one place, not mentioned here, where the people lived on stilts, their houses were on stilts, and it was accepted practice to kill the second-born twin. What? You killed the second-born twin and you buried the second-born twin under the stairs. Now, to some people here, especially if you happen to be a second twin, you probably think that's horrible. And I'm not saying that it's what we should do in Washington, D.C., but there's probably reasons that evolved. For example, in twin births, even in this country, the second child born, if one is going to have cerebral palsy or have problems due to the delivery because of the slower delivery, it's usually going to be the second born. If it's a vaginal delivery with the two twins, usually the first twin comes out head first, so that twin is going to be okay. The second twin is more likely to be a breech because of how the twins are entwined, and that's another reason why the second twin tends to have more problems. So that and also in countries where there is very little food and very little resources, for a woman to have two babies to breastfeed, one of them probably is not going to survive, and frankly, the probability of neither one of them surviving is greater if there's two. So we can look at it from our eyes and say it's wrong. That doesn't mean I would go teaching people to do that, but there's a certain amount of acceptance that's necessary. I'm trying. I don't know if did that answer the question? Okay. Any other kinds of questions?
Yeah.
Yeah.
You see, I'm confused that we're trying to reconcile science and belief system.
Mm-hmm.
Because I think scientists have given a lot of explanation to most of the belief system people have as a culture.
Mm-hmm.
Because for me, I believe so much in science. And like the example you gave that giving names to kids that they are born, that if you give them names, they are likely that the spirit will take them away. Now, for me, I was thinking that the WHO should also try to conscientize and educate the people that those systems, for me, I think they are good. They are good in a way that you cannot help to cite because science has given a lot of explanation to all those systems people have as a culture. So what I'm trying to say that is it one of the programs WHO is front that look, if people are having a political culture, even when it is not promoted, we should allow them to have.
I don't think I understand. I very much understand your question. I don't think I know how I don't know WHO's specific policies on those kinds of things well enough to comment on that. So I can't speak for WHO.
But you can speak from scientific aspect of it, as it affects the cultural system.
Okay, from my personal perspective, I think it's important to understand, first of all, if you go in and tell any group of people for whatever reason, science or religion, you can pick your economics, you can pick your tool, because science is really only one tool, and say, what you're doing is wrong, my way is right, people are not going to hear you. The minute you leave, they're going to go back to doing it their own way. So what's really necessary is to work together to see what are the things that you can do to make the most difference. And there are some things, like for example, I'm trying to think of the country I was in. They wanted to, was it vitamin A? They wanted to, I'm trying to think of exactly what it was that they were trying. I think they wanted to supplement food with vitamin A, and there was a real strong cultural reason against, I don't remember the details of that well enough to use that as an example. But, well, like with a lot of maternity practices. Okay, a good example is when a baby is born in many cultures, okay, so you've got the umbilical cord, you cut the umbilical cord, and they'll put animal dung, animal poop on the umbilicus. That causes infection, and the baby dies. So that's a situation in which a very simple change can have a very big impact. And so there you need to use the science to make the change. But in the case of whether or not you name a baby when the baby is born or when the baby is 3, doesn't really make a difference. So that would not be at the top of the priority to try to change. You have to kind of look at what little changes can make the biggest difference. And move, because unless the people accept it, it doesn't work. Look at seatbelts in the United States. How long did it take to get people to use seatbelts? Or look at smoking. We can, how many, and you don't need to raise your hands, I won't embarrass you, but my guess is that there's some people in here that smoke cigarettes. And my guess is, everybody in here realizes that smoking cigarettes is not a healthy thing to do. But the knowledge doesn't change the behavior. And so it's important to encourage, it's the behavior change that's really what's needed, and to set priorities. But in terms of where we are today, there are extensive, and if you go on the National Institutes of Health website, that's probably the easiest place, and look under human subjects. There are extensive controls in terms of how human subjects are protected, as well as animals being protected in research protocols. Now, sometimes we may not know the impact of what we're doing. And not only, and I'm not even talking about scientific research. You might look at asbestos as an example. You know, I'm sure that asbestos was used before people knew the adverse health effects. So sometimes when studies are designed, it's not known, or not even studies, but even just in terms of day-to-day life using new things, you don't always know all the adverse consequences of it. But there's extraordinary efforts to prevent things like Tuskegee in today's world with the protection of human subjects.
Just keeping in mind that the experiments for the people in Guatemala happened post Tuskegee.
Yeah, I mean, I can't comment on something I don't know about.
Cool.
Yes?
As far as your example of cutting the umbilical cord
Mhm.
and educating the population around death in infancy,
Mhm.
how do you work with that population if that is kind of an enculturated practice? Or how?
Okay, there's a lot of research done on different ways of doing that. And that's not my particular area of expertise. But one of the things is to start, okay, one way is to start with the leaders in the community and to educate the leaders of the community, so then it becomes them who are doing the teaching. And the other thing is the more you can become a part of the community, the more effective things are.
Thank you very much, Dr. Johnson. I'm sorry we have to end here. We do have to go on to our next speaker, so thank you very much.